Good evening, good morning, and good afternoon. Welcome to Donate PPE for Medical Physics Webinar 5. Today, I am pleased to welcome Dr. Holla, Deputy Chief Medical Physicist of Ruby Hall Clinic, Pune, for delivering lecture. Thank you, sir, for volunteering the lecture. Dr. Holla is one among the advanced medical physicists in the country with unique exposures in advanced medical physics at premier health organizations. He has been involved in the setup and commissioning of many advanced technologies and equipments in healthcare. His experiences ranges from very high-end linear accelerators to specialized equipment such as tomotherapy, Radixact, and Cyberknife. He is an active member of the College of Medical Physics of India, in addition to several other involvements academically as well as clinically. Today, he will be talking on the challenges in real-time tracking of moving targets in Linac to Cyberknife. As you know, the campaign is to invoke awareness on safety and to generate support in terms of PPE donations. The word medical physics in the campaign represents our profession, and Donate PPE will be our commitment to our healthcare professionals fighting this pandemic in front line. Please feel free to use the question tab to type your questions, as the microphones will be muted throughout this webinar. You can also type your message during any time of the webinar. I thank Dr. Holla once again for volunteering this lecture, irrespective of his busy schedule and other commitments. Dear friends, please join me today in welcoming Dr. Holla on the stage by giving your full attention. Sir.
Thank you, Sajeev, for giving me this introduction, and I thank Ankokar Troop for giving me this opportunity for giving me a talk. So let us discuss about the challenges in tracking of the moving targets, especially in Linac to the Cyberknife. I will try to cover up from Linac to Cyberknife what and all are the systems being used currently in the market. So let's go back to the basics and let's see from the beginning which organ move. We have two types of movements in the organs. One is the breathing related movements. They are like in the kidneys, pancreas, lungs, esophagus, liver, and breast. And peristalsis based like gynec and GE tumors. So they all move. Now, what is tracking? You know, the whole concept here is a tracking. The definition of the tracking is like the radiation beam follows tumor as the tumor moves. So this is not something new to us because the tumor is moving. We cannot say that patient is moving. It's the tumor which moves, but we can make or we can take care of the patient's movement with the help of simple X-ray images. But to take care of the moving target, even if the patient is not moving, is the biggest challenge here. So if the system can detect target, it can correct for motion directly. And if system cannot detect target directly, it must track something that moves with its target. That means this is a surrogate question. So assumes fixed relationship between target and fiducial motion if you are having a fiducial, or if some object or if something else which is indirectly monitored to monitor the target motion, then we assume a fixed relationship between both of them, the target and that particular object. If the assumption is not true, you know that accuracy of the treatment delivery may be compromised, which is not recommended at all. This is a reference which I got it from TG76 from AAPM. Coming back to our history here, tracking. What is the best example we can give for tracking? The best example what we can give in this particular epic picture is Arjuna is trying to hit the fish by seeing the fish's image on the water. You know, this particular, if you take it as a tumor or the target which is moving inside the water, and by looking at this particular one, he has to hit the eye of the fish, which is much higher than this particular object. This is what exactly we're tracking here, and we are hitting the tumor. So this is exactly the example which I want to give. Now, why tracking is required? Let's look at the dimensions of the tumor. If I have a tumor of 5 millimeter in radius versus 6 millimeter in radius and 7 millimeter in radius. If it is 5 millimeter, it gives you about 0.5 to 3 cc if you apply a simple correction there. And 6 millimeter radius, if I just increase from 5 millimeter to 6 millimeter, which gives me a 73% increase in the tumor volume. If this same tumor is being again expanded by 1 millimeter extra margin, the tumor volume increases by 175% in terms of percentage with respect to the 0.5 to 3 cc. So this tells us, so when we irradiate this versus this, the normal structure surrounding is also more and more irradiated. So this tells us why tracking is required. So what are the motion management approaches we have? We have actually developed this motion encompassing methods even in the era of cobalt-60 teletherapy machines by means of taking a fluoro X-rays and seeing how much is the tumor extent movement and movement of the tumor extent and encompassing that with the field sizes. So that is what we have been following. The same techniques are still being followed by many of the people, and we have a little bit modern from this is the respiratory gating techniques and the breath hold techniques and forced shallow breathing like the compression, abdomen compression, and the next one is respiration synchronized techniques, that means a tracking. So I will be going through each one of them to some extent to give you a brief about what exactly each technique says. So coming to the concepts here, we have different concepts. So suppose you consider this as the extent of maximum inhale and this is the extent of maximum inhale and maximum exhale here. The tumor is moving in between inhale to exhale. We actually give margins to encompass the whole tumor motion, and we call it as a PTV, and we treat this particular PTV. This is what actually we have been followed in the conventional free breathing techniques. Now, with the concept of internal target volume, where I can exactly see how much is the movement, we can actually further give margin to ensure that at any time or at any cost, we never miss the tumor, and we give enough margin around the tumor and give a treatment for the PTV. This is the internal target volume concept. And gating, in this case, particular gating cases, what we do is either we choose maximum exhale or maximum inhale, or we choose any particular or specific space where I want to treat, and you create your PTV or ITV and PTV in that particular phase only, and treat with the lesser margin, so that because whenever the tumor moves into this particular location, this is not going to be treated, or whenever the tumor is moving in this location, this is not going to be treated, so vice versa. So this is how actually we have followed in the gating or breath holding. Now coming to the tracking, when we want to treat when the tumor is moving without giving additional margins, here the complexity increases because the linear accelerator should be capable of delivering the radiation dynamically. This is also called as a dynamic radiation delivery. Here, irrespective of the phase of the tumor motion, the tumor itself moves at the particular time. The linear accelerator should be able to track this and deliver it to this particular tumor volume. And this is the most efficient way of tumor dose delivery compared to any of them. But the technology requirement is also very high, and the involvement of all the high technology makes it more and more complex. So for a successful tumor tracking, what do we need? We need, first of all, identification of the tumor position in real time. That means on this particular time, where is the tumor? So this real time is a big question because there will be a lag, there will be system lag, maybe due to the hardware requirements or hardware limitations, there will be some system lag in that. Still, we should be able to call it as the real time. The task group report specifically specifies the system lag should be less than 30 milliseconds. So anticipate tumor motion based on the system, the tumor position identification, anticipate where is the actual tumor. For this, we use something specifically called as the predictive models, which have been used in many of the systems, many of the areas. So we use the predictive models in this particular case, and we predict where will be the tumor in the next 1 second or next 2 seconds, and see whether the tumor was really there or not. If the tumor is not in that particular predicted model, the difference, if it is more than the cutoff, the system should be cutting off or stopping the treatment. So in this situation, again, see what is the position required to make it in the threshold of this. So reposition the beam in the real-time basis. That means, as I said, the lag between identification and reposition and delivery should be less than 30 milliseconds. So adopt dosimetry for changing target and critical structural locations. So how do we do this, or how do we incorporate these stuffs in our real-time basis? The one simple thing is direct visualization. If tumor is visible, with the help of X-rays or 3D imaging or 4D imaging or MR imaging or ultrasound, any of them, the direct visualization of the tumor is required. In some situations, it happens like the direct visualization of the tumor in specific locations or specific direction is not possible. In those situations, we go into the indirect visualization by putting a surrogate. Surrogate means a representative of the tumor which moves with respect to the tumor with a specific correlation between a surrogate and the tumor. So this surrogate could be an implanted fiducial, or a target position surrogates will be there, or bone landmarks, or electromagnetic transponders, or surface imaging. Any of these can be used. So using these two concepts, we can at this point of time target and deliver the radiation for the moving targets. As I said, what is the requirement here? A latency prediction algorithm, and TG76 recommends again up to 0.5 to 0.3 seconds of latency is acceptable in this case, in this particular one. So what do we need? So for example, we see where is the tumor and what do we do next. There are two concepts again here. Either we realign the beam or we realign the patient. So there are two things. One is move the beam, like you can use MLC, you can use jaw, or you can tracking, or a robot mounted Linac. So these things will move or realign the beam. The other option is move the patients. In this case, move the patient using 60 couch, or reposition the couch by gated delivery, or a gated delivery using a respiratory gated tracking system like RPGS or RPM. So this is actually moving the patient, and this is as per the moving the beam. So this is actually how it is done. Coming to one simple system by the variant medical systems, the gated delivery. In this case, place the gating marker block on a patient chest during the CBCTO acquisition as shown in this particular picture. There are 4 reflectors here which reflects the infrared coming towards this particular the block and goes back to the camera, which is also installed inside the treatment room. This treatment room absorbs and emits and absorbs back, and this is almost a GPS system where actually, so this is how it is being displayed here. A marker is being kept on the patient head, and there will be a time lag again, and you can see a model is being created here for the patient's breathing. This is how it is being done. So how does it work? A filter is again being used by the variant medical system. It's a crucial part of RPM software, and it predicts the patient's breathing pattern. For example, it takes the previous information and tells in next 1 second the patient breathing will be like this. It's internally, as of now, it is not shown to outside window. It predicts what should be the breathing, and on real basis it collects the information again. How actually is this? So what is predicted versus what is actual is the cutoff limit by the system. If that is beyond the set limit, the system understands that the patient is breathing abnormally and cuts off the beam. Once the pattern has been established, the predictive filter continuously verifies that this pattern is being followed. The patient coughs or otherwise interrupt the predicted breathing, the machine gates off the beam. That means machine turns the beam off. This is how actually is being done by the RPM or RGS system. So in this case, this is the tumor which is in the red color, and this is the surrogate or the tumor marker which you kept on the patient's surface. And if you can say, this is the sinusoidal wave here is a patient's breathing pattern, and the patient, when it comes, for example, you have decided end of exhale, end of inhale as the patient treatment phase which you have collected here. Whenever the patient comes to this particular phase, this also moved from here to here, and it is actually delivering the radiation with the help of this guidance. That means this green surrogate has guided the system to go on when the tumor comes here. Only the assumption here is this surrogate and the tumor is having perfect correlation. So this is actually how it is done. Whenever it comes back, it gives the radiation dose or shot of radiation to that. It is very inefficient in terms of delivery because the delivery takes very long time. During the treatment, additional KU images can be acquired at a specific interval of MUs. like the gantry angular time. If you incorporate this also in addition to the gated delivery, what happens is when if you have put a fiducial in the patient's tumor, like for example in case of prostate, and the system can generate images or acquire images while the treatment is going, and irrespective of the treatment time or gantry angle, and track where are these particular markers. The marker is actually going out of the predicted place, the system can turn the beam off. So this is what we call it as auto beam hold, which is also again incorporated in by some of the vendors. The other best option which I have found, which is very simple and pure physics based concept, is quantification of patient's lung volume or the tidal volume, which is done with the help of a small spirometry technique, which is actually, you can see here, a spirometry is here, and patient's volume, the lung volume, is connected to the spirometer and actually is being quantified. So this is called as active breath coordinator. Here what actually we are trying to do is arrest the movement of the tumor by asking the patient to stop breathing. That means it's a little inconvenient for the patients. The breathing stopping or the breath hold capacity should be at least 20 seconds for the patients. Otherwise, it is not possible at all for the patients to breathe. So here what we do, the patient gets the treatment whenever patient holds the breath till the time machine is free. So this is also not very efficient. It is very good if the dose rate is very high. The prerequisite for this is your Linac should be able to give you very high dose rate. Otherwise, what happens here is when you go out, the patient cannot hold it for more than 20 seconds or something. The treatment time goes very, very long. And that is one of the disadvantages of this technique. And not all patients can go with this particular technique, because patients should be able to have a good amount of the lung volume or the capacity to hold the breathing. So that is not possible specifically for some of the old patients or the patients coming with some lung metastasis or lung tumor, which is very inconvenient for the patients. So this is how actually is being displayed for the patients as well as for the console. Whenever this blue line goes above this green threshold limit, kept it for the patients. We usually keep about 0.8 to 1.2 as a threshold for the patients. Whenever it crosses the green, the Linac activates and Linac delivers. Whereas patient will be having their own monitoring system, where if the patient is uncomfortable, they can release it and release their breath. Till that time, here if you see, the patient's nose is being blocked. Patient cannot breathe in the nose. Patient is forced to breathe only in the mouth. So that is the system called as the active breath coordinator. But during commissioning, what are the challenges we face for this kind of system is, for example, if you look at simple DIBH, a deep inspirational breath hold technique. So you have taken a CBCT, or you have taken initial planning CT with this particular concept, and you have asked the patient to hold the breath and take the CTs. But at the time of treatment, when we take a CBCT with the same position, just do a simple subtraction images from the DIBH CBCT to CIBH CT simulation. Find whether the patient is breathing with the same pattern or not, because both the systems, which is in the variant as well as in the Electra systems, will always give you some margin of about 0.3 or 0.4 of millimeter of breathing respiratory amplitudes. So sometimes that is too much for some patients. So analyze this before giving a thought whether this is okay to continue. The difference is okay. The difference is almost from dosimetrically. That also you can actually get this particular CBCT into your CT and deform it and do the dose calculation, see whether the dose calculation is having the same parameters as you expected. If there is a difference, that means your DIBH protocol needs to be fine-tuned. So this is what needs to be done at the time of commissioning of this technique. The other simple technique is the AlignRT, which is the OSMS, that means the surface monitoring system, which is also called as SGRT, surface guided radiotherapy. Here, what the system does is it tracks the patient's skin surface. One simple assumption this whole system does is there is a perfect correlation between the skin surface and the tumor motion, which is not true at all in any sense. But for majority of the cases, this can be tried. Here, what we do is there will be electromagnetic transponders, which is implanted inside the patient's tumor, and there will be a detector here which to detect spatially. That means again a GPS system is being used, and we can actually incorporate or integrate this whole system with the leader accelerator, so to track it. So if you see this one picture, it's a case of prostate here. This is how the Calypso transponder looks, and you put it inside the prostate of the patient and see this will be monitored with the help of a GPS algorithm, and you see how is this moving. If this is moving out of the coordinate, the system can either reposition the patient or cut off the beam. So this is how actually is done. Now, what are the challenges what we face in the gating system? One basic challenge what we face here is respiratory gated beam delivery cannot facilitate margin reduction unless combined with respiratory correlated image guided. That means we may have a good 4D CT or respiratory gated system during CT simulation. Do we have the same system when we are acquiring a patient positioning images like CBCT? Do we have a 4D CBCT, or do we have some sort of the more than 3-dimensional CBCT images so that we can actually monitor it properly? So this is one of the challenges that we face, because many of the systems don't give you 4D CBCT, or even if you have it, may be very effective, cost effective as if you consider it is very expensive to implement in the system. Why do we need it? If you look, most of the systems, whatever I have discussed so far, is under the impression or under one simple assumption that the marker position and the tumor motion, the marker motion and the tumor motions are perfectly correlated to each other. So which is not true. If you look at this particular publication in the TG76, again, comparison of external marker block motion with the internal motion of clinical target volume. Here if you see, so there are the marker motion you can see here in the green color, and the beam on phase is here, and the tumor motion, this is how actually the relative motion we planned it on the day 1. After day 2 or day 3 or day 4, the patient will have a significant phase shift. When the patient is having a significant phase shift, respiratory gating thresholds are set using the old marker set blocks only. Here if you see, the tumor motion is in this green position, and the marker motion still says I'm okay. So based on the marker motion, the beam is delivered, but tumor is offset with respect to the marker motion. The beam on pulses are actually in the forbidden zone here. So forbidden zone of the initial planning, the beam is on. So this is actually the risk what we usually get. So because we know that the tumor motion and the marker motion is not going to be in the same one. So these are the directions. If you see in each, based on, for example, see a lung, if you take, based on the tumor location in that particular place of the lung, either upper, middle, or lower lobe lungs. So how is the phase shift can happen on day-to-day basis is again is based on some published documents. So in simple technology, how we can explain this? So we have seen how the delivery is done in a phased or a gated manner. But what happens if in this particular situation, if you see here, the beam delivery happened and at the time when there is no, the tumor was not moving in. So how to overcome this kind of position is by placing a mean position registration using 4D CBCT. That means if you incorporate 4D CBCT during the setup, and you find out, take a 4D CBCT of the patients and see where exactly it is matching with your planned one, take that particular one and move patient accordingly to the mean or averaged position and treat. This is one of the propositions proposed by some of the vendors on this particular problem. Now coming to the new technologies again, some of them are very recently incorporated in the real-time tracking concepts. One of them is by Radixact. So here they already have something called Synchrony, which I will be explaining you in detail what actually is that in the Cyberknife. They try to incorporate the same thing with the Radixact. So what happens here in this particular system is the jaw opens symmetrically on the target. The target shifted in superior direction, jaw moved to the compensate. That means when the tumor moves in this position or in this position, the tomotherapist jaws can be asymmetrically moved and tracked based on the position of the tumor. That means the jaw tracking or MLC tracking, both actually can be done. So this is how actually they incorporated in the Radixact. They have called the KV source, KV detector, and jaw MLC and the table, everything as it is. Here if you see, the whole system can move in 2 different directions, and MLC also can have a different movements to incorporate the motion of the tumor based on the feedback coming back from the tumor. The feedback system maybe again you can put a surrogate or you can put a fiducial inside the tumor of the patient. So based on the fiducial movement, you can see where exactly is the tumor, and the jaws are asymmetrically open to incorporate the motion of that. So pictorially, if you see that the jaw tracking move the beam in this particular direction, and yeah, this is actually how it is done in the Radixact system. So now whenever the tumor moves in that direction or in that direction, the MLC accordingly opens. Same thing happens in this space also. The jaw accordingly opens and treats it. So that is how it is being incorporated in the Radixact. Coming to the basic question of synchrony, which is incorporated in the Cyberknife system. The tracking options, we have plenty of tracking options in the Cyberknife system, but I'm not discussing anything about the static tracking options. Instead, I will be more focused on the tracking used for the moving targets. So we have different systems in the Cyberknife. One is using the Fiducials here, which is used for liver and some pancreas or some cases like prostate and all. And we also have synchrony, where actually the system is being used for calculating the patient's breathing model and generate a model based on the patient's feedback, directly coming with the help of an infrared emitter, which is placed on the patient's chest like this. Patient is being asked to wear this vest, and on top of that, there will be some infrared emitters, which is being again captured by the system. So how it works? So if you see here, this particular, the patient is actually getting treated here. Constantly, the system emits based on the patient's breathing, infrared emissions happens here, and the camera quantifies it and gives a breathing model and gives the feedback to the system, again based on the x-rays which is being taken continuously, which is floor and ceiling mounted x-rays, and the robot takes a different place. So this is how actually, so from this feedback, the position of the LEDs here, we get a patient breathing model like this, and x-rays are being taken in different phases of the patient breathing model, and this is used for giving a correlation model between the tumor motion and the patient breathing. So tumor motion and the patient breathing, we usually call it as a comet graph. So that is being generated in Cyberknife, and the lung optimized treatment techniques or the Cyberknife synchrony model, it actually detects the tumor in the 2D images and calculates what is the requirement here and calculate this kind of model in the target position, and the correlation model is being generated here. Target is being moved in this particular direction only, and the robot understands these movements and makes necessary changes in the position of the robotic head. That is how actually it's being done. So we call it as a comet graph from the Cyberknife. So it's with the help of two different X-ray images being taken, this particular decision is taken, whether the robot has to make the arrangements or the cutoff has to be done for the treatment based on the X-ray images taken. This is actually in the ceiling of the room, and these two images are in the floor of the room. So now just imagine a situation where you are able to see the tumor in one direction and you are not able to see tumor in another directions. So this is what we call it as the one view. If the tumor is visible on both the images, we say it is a two view. If the image is seen in any one images, we say it is a one view. If tumor is not seen on any of the images, like the tumor is very close to the mediastinum, we cannot see it in the 2D X-rays, then we call it as the zero view. So these are the three options: two view, one view, and zero view. In two view, the margin to the tumor treatment, because we are seeing in both directions, so the margins given are very, very less. Whereas in the one view tracking, the tracking where we are not able to see the tumor in that particular direction, you give additional margin. In case of zero view tracking, this is a blind hit. So give your concept of ITV, ensure that tumor is within this particular, that much margin you give, and use a spine tracking and see and treat the patient's lung. So this is actually these three techniques used in that. So, but the challenges here is, which is the best technique? If I use the same tumor movement techniques in trauma therapy, a simple trauma therapy. So usually happens, there are a lot of publications saying that yes, trauma therapy can be used for lung tumor, trauma therapy can be used for the liver tumor and all. So just to check this particular aspect, what we did in our center is, I designed a small cot phantom here like this, where you can put a gapchromic film in the sagittal plane and push this inside our dynamic thoracic phantom here, which is CIRS made again. And we simulated the patient with this known specific tumor motions in superior, inferior, left, right, and anterior, posterior directions, and motion amplitude during the stimulations. Now, during the delivery, the simulated motion amplitudes have been changed. For example, if the patient is being simulated with the 300, that means in the superior it is 3 mm, left and right, anterior, posterior it is 00 mm. During delivery, we made it 330, 303, 333, 3500, like keep on increasing in all the respective directions, all the 3 directions, and found that that many irradiation is done for the film, and that many evaluations have been done, and gamma analysis is being done for that film. As you increase the planned versus delivery, the planned versus delivery is increased beyond 3 millimeter, 3 to 5 millimeter, the gamma reduces less than 80 to 75%. So this is what actually we have seen here. That means if you have planned a patient with a 3 mm margin or 5 mm margin you are given, during delivery, if the patient breathing is not same as the simulation, the patient breathes differently, which makes the tumor to move more than 5 mm, the tumor delivery is not appropriate or not accurate. This is what actually we have seen. And the same thing, we extended this particular study further to know what is the effect of breathing cycle. At the time of stimulation, patient may be having a 4 seconds breathing cycle. At the time of delivery, over a period of time, patient may be taking 5 seconds of breathing cycle. That means cycle is a little longer than that. If that happens simultaneously with the movement increased, you can see if the patient is having 5 seconds for breathing, and anything above 3 mm of planned one will give you a dose reduction of about 20% in terms of their gamma analysis. So this is a drastic reduction in the gamma values, the gamma passing values for those cycle changes. Now, another option here is like you have started the treatment, for some reason patient is not able to cope up, you may have to interrupt the patient treatment. When you interrupt the patient treatment for the lung tumor, when the lung tumor is moving, but the chemotherapy is able to take the treatment back from the same place is a big challenge. To analyze that, we have done interruptions here, the delivery interruptions for the different one, like the blue one is the no interruptions, the first interruption, second interruption, third interruptions. The tumor movement is more than 5 millimeter and 3 and 3. First, second, third interruptions, the dose passing rate is very low, and up to 5 millimeter, the passing rates are okay. The tumor is moving more than 5 millimeter, then interruptions again reduces the dose coverage for the patients. So this is what actually we found. These are the films which we exposed for the different one. You can see here how the dose coverage comes down. The black one is the planned one versus the pink colored one, which is actually the delivered one. As the tumor motion increases during delivery, how is the delivery isodose plotted on that film? So this on this particular software, this is how actually is deteriorated in the particular system. Now the question comes, which is the best technique? So nothing is foolproof. Everybody is having 1 or 2 small issues when they were talking about their gating techniques. Now which is the best one? Whether the ITV based approach is better, or DIBH is better, or a CK based synchrony options are better. So we wanted to check this particular comparison in our center. So what we did is here, we compared it for an actual patients like mid lung, upper lung, and lower lung tumors of the CA lung cases. We have drawn the images, the tumors on their respective CT images like 0 view, 1 view. You can see a 0 view, 1 view, 2 view, average IP based, and DIBH. These are being compared here. What we found here is for upper lobe, mid lobe, and lower lobe images here, the PTV volume between these 5 techniques classified based on the location of the tumor in upper lobe, MLM, left lobe of that, and the variations in the dose coverage like V5%, V10%, V20%, and V30% among techniques have been compared. What you see here is for upper lobe, if you take alone, most of them are actually giving the same dose coverages like V5%, V10, V20, V30, irrespective of the techniques. For upper lobes, they are almost same. Whereas for the mid lobe and the lower lobe, the differences in the percentage lung volume, if you see here, the 2 view gives you the least lung volume. The next one is the average, the DIBH one. This is a 2 view, and this is DIBH, and this next comes the average, and this is coming the 1 view, and this is coming for the 0 views. So this pattern is being kept for all of them. That means the lung irradiated volume in case of DIBH and true view of Cyberknife are very close to each other, and they're very minimum compared to average IP and one view, and of course zero view is totally not acceptable for the patients. Same thing in terms of mean lung dose. If you see in this particular case example, the true view and DIBH gives you almost same mean lung dose, whereas the average IP gives a little higher, which is very closely with one view technique of Cyberknife, and zero view is giving highest dose. For upper lobe, this pattern is kept constant for even mid lobe and lower lobe, but the differences between the zero view to the two view and zero view to the two view, if you see the zero view to two view difference is less in upper lobe, whereas mid lobe and lower lobe, the zero view to the two view gap or the difference is very high. That means for cases like in the mid lobe and lower lobe tumors, the Cyberknife's two view and DIBH is the best choice with respect to one view to zero view or average intensity based projection images. So this is what actually can be interpreted from this. If you look into the other aspects like the low dose and everything remains almost the same. There is no difference in the low dose coverage at all. Everybody gives more or less same only, and the coverage, dose coverage for the target was kept constant in all the plans to give or to yield the actual true lung volume irradiations. Now, common mistakes what we do. For example, if your center is planning to do a fiducial implant for your prostate case or liver or something, what do we do basically is the clinicians will come and just say, okay, I'm going to put one fiducial, that's it. But look at the physics behind that. One fiducial, if you put, we will not be able to see anything more than 2 dimension. It is a very simple physics and mathematics concept. So minimum of 3 fiducial is required, or 4 to 6 is very highly appreciated, but minimum 3 is required. So okay, you put 3, then the clinician will say, I'll put all the 3 clusters together. Again, the problem again comes back to us. 3 when we want each one of them at least separated by 15 millimeter of gap, and the gap, not only the gap, the angle between both of them or between 1 to 2 should be at least more than 15 degree. If it is less than 15 degree, all of them come same in the images or orthogonal images or CBCTO. So it is not ideal case for us. So these are one of the challenges to put it. And if you don't, even if you have a machine like Cyberknife, if you don't follow this rule, what happens? So to just check that, taken a simple phantom and put 4 fiducial in that and scanned and created the plan and set up the phantom on the plan and ensure that everything is perfectly matched as per the institutional protocol. Then I deactivate 3 fiducials from that, because in the day 2, the patient, it happens like we have put 3, but all 3 will not be able to use for aligning the patient because they have migrated. So the same situation is simulated. These 3 have been migrated, so I'm not able to see them. So I'm seeing only 1. So then what I do, when I select 1, automatically the 3 coordinates have gone. Instead of 6 now, previously I had 6 coordinates here. Now I am going to have only 3. The remaining, the pitch, yaw, and rotations have vanished from the window. That means we are not able to track, we are not able to see the 6-dimensional movement. Now, what if I rotate the whole phantom by 90 degree? I rotated the whole phantom by 90 degree. Since it is single fiducial, still my system says you are all right to go. That means without having any other fiducials, the Cyberknife fails to track single fiducial and give an accurate, because I know that I have made 90 degree rotations here. Still the system says you're okay to go ahead and treat. So this is what exactly happens. So it is our responsibility to train the corresponding team to ensure that everything is done properly. So the moment I activate back the 3 more fiducials, you see the differences exactly. It is telling me what is the problem. So this is actually the rule is here. Suppose this is the tumor and you want to place a marker on the patients. If you place the marker here and if the tumor is here, you remember your marker to tumor, for every more than 60 millimeter in size, you need to add 1 millimeter of extra margin to the tumor, because there is a simple physics behind that, the triangle if you form it. So 1 millimeter is, so 0 is 1 millimeter in this place. So that margin you remember to add. So ideal situation is this should be here. There's no question of tumor here and the fiducial here. So if you have 2 tumors to be placed, the best thing, if you want to track both of them, make sure that your tumors, both the tumors are less than 60 millimeter with respect to the triangle formulated by this, which is not practically possible to place because it's on the patient, not on the phantom. But try to keep whatever is the best possible. If you are having a situation like this, one tumor is very close by, another is still far, then remember this is going to have less margin, and this is going to have more PTU margin while treatment. So these are the things actually. 60 mm and more 60 mm will have. If you have liberal enough, if the patient is cooperative and no other comorbidities for the patients, ideal situation is make this separate and treat. That is the ideal best situations. So in conclusion, irrespective of the technologies what we have, workflow protocols, careful replanning, attention to detail, and a collaborative treatment team is required for seamless flow of the online tracking irrespective of the techniques. So it is not only the system what we have, how do we implement it on the patients, how do we implement it on the system and in the institution is very important. So thank you very much for this talk.
Thank you very much, sir. Thank you very much for the impeccable presentation. And as you have been mentioned, two approaches. One is moving the beam and the other one is moving the patient couch. So among these two approaches, maybe which one do you recommend? Which may be in your experience, which may be having lower error compared to the other one?
Moving the patient is the one which is cost effective and everybody uses it. But moving the beam comes at a cost from the vendor, which is very, very costly. Either you need to go for some special tracking algorithm software, which is very difficult for many institutions to follow it up. But if you have given a choice, if you have good financial background, then moving the patient is not recommended. Move the machine and make sure the patient is comfortable. That is what my choice is.
Okay, thank you, sir. And now the meeting is open for questions from the audience. We have many questions now already. And the first question is, what QA method can we use apart of the accuracy applied synchronic QA tool or dynamic motion phantom? And what detector system can we use apart from Philips?
QA system, the best thing what I follow is the CIRS. When you go for CIRS dynamic phantom, you can buy the film slot, or you can buy the TLD slot, or even you can go for the OSLD slot in that and place them and deliver the dose exactly and see. That is the best option to buy. But chamber wise, you can use the 0.cc01 chamber for dose quantification in the center of the tumor. That is pretty good enough and gives you within 3% of the dose delivery.
Thank you, sir. And I could see there is one more question. How do you compare the frame-based systems with the frameless systems in tracking?
See, frame-based we use only for brain. No other systems actually being used. But frame is excellent, no doubt about it. No comparison from frame-based to frameless-based in terms of the accuracy what you can reach. But what happens? For of late, what is happening is the frame-based system has almost lost its place in the radiation oncology because of the involvement of non-radiation oncologists in the field, like the neurosurgeon is required for that. And also the new latest softwares coming, it may be from Varian or it may be from Monaco, from Electra, they are not good in quantifying or stereotactic coordinates for the frame-based one. Like what we used to have in the previous, like what you have in the Gamma Knife or what you have in the brain lab, that kind of accuracy is not there now with the new systems, because they're not having a straightforward coordinate system incorporated in the planning system. So keeping this in mind, when you have an IGRT system where you can see what is happening with the 6D couch, I think frameless is good enough, and frameless gives you more comfort and easiness, because from when you want to do frame-based one, you are like, one day you have to finish everything. You are under a tremendous pressure to do that. When you are having frameless one, it is like a normal situation. Even SRS, SRT has become normal now with the frameless one, with the help of 6D couch and the more options of CBCT coming in, the clarity of the CBCT. I think frameless is more suitable for this particular situation.
Thank you very much, sir. And there is one more question. What is the scope of zero view, and why there is a situation with zero images from both imaging cameras?
Yeah, see, zero view is some in some way you can say it's a blind hit. You are not going to see anything. It is going back to the basics, what we used to have in a tumor encompassing method. It goes exactly with that. You're looking at the spine to ensure that patient X, Y, Z and all rotation from the spine point of view is good. And with respect to the spine, what is the margin you have to give? You have calculated it. You expand your PTV accordingly and give a radiation to that. But it is not recommended. If the Cyberknife fails in seeing the tumor in one view at least, then I don't recommend Cyberknife to be used, because the treatment time is also very high for as you increase the volume of that. So zero view, for me, I do not recommend zero view in Cyberknife.
Thank you, sir. And next question is, what is the best tracking and gating system in the market?
This is the big question. Actually, we don't know which is the best tracking, because everybody has got their own problem. If you ask me which is the best one, I will ask for a lung tumor, if the patient is capable of holding the breath, then I call it DIBH is the best one, because you know that you are arresting the tumor motion, your margins are much less, and if you are able to do CBCT with the help of even with the DIBH, that is the best one. Like either DIBH of Varian or ABC from Electra is the best among all of them, because all other gating things will have their own issues. When you really evaluate them, you will be discouraged to use that.
Thank you, sir. The next question is, kindly share your experience for fiducial tracking with the Synchrony. 1 minute. Yeah, in Cyberknife VSI model with 12, we facing through tracking with the 3 fiducial and creating correlation model. Even all fiducial placed as per accurate recommendation. In correlation model, we are not getting correlation error. It will be orange color error. Please share your experience.
Yeah, the correlation model, if you're not getting good, that means the fiducial placed is not accurate. Because as I said, there are rules which you need to follow when you want to put the fiducials. The minimum is 3, they say, but there is no harm in having more than 3. It's better to have 4 to 5. Technically, it is possible for the patient. And the gap between the fiducials should be good enough, at least a 15 millimeter between 2 fiducials. And the last thing is the density of the fiducial. If you're not using a proper gold seeds, the Cyberknife algorithm is returned to track only those particular gold seed density and higher than that. Otherwise, it will not be able to give you any correlation model. I think if you fix these 3 things, you should be able to get a good correlation model. If your correlation model is still bad, you please go back to interventional radiologist and give them the training what actually you expect. Like you can put 1 or 2, 3 fiducials in a small phantom and expose it and see how is it coming, or the correlation model is coming for that, and give them. And sometimes the model from orange to green, by just making small changes or tweaking in the tracking range, you can actually get from green to the orange to green. So you can also try that option in your window.
Thank you, sir. And next question is, for ITV based SAVR treatment and monitoring, is there a recommended predictive filter setting?
No, these predictive filters are not visible to us. It's all inherent, incorporated in the website, in the software. We cannot see that or tweak that to any extent. That is incorporated inside, it's embedded inside the software. We cannot see that.
Thank you, sir. That's all the questions from the audience at the moment. Sir, in your experience, do you have any experience with SGRT systems, the OSMS systems, which are available in the market? Could you please?
I have seen on that. I have got some training also on that. It is good for some basic head and neck, and if you want to treat some chest wall and all, I think that is very good because you can get exact orientation of the patient. But I don't recommend it for SBRTs or SRS, SRT and all specifically, no, because it is actually a big no, because the correlation between the surface skin tracking to the tumor is not established anywhere by that system. So as long as that is not there, I am not comfortable in using it for SBRTs.
Okay. And somebody is typing the questions, I could see that. It is, okay, so I think, yeah, it's not coming. So I think our time is almost getting over. And yes, sir, thank you, sir. And thank you so much for your time and sharing your knowledge with the audience. And,
Thank you.
and I also thank all the audience for your active participation. And there is one more question. He has typed it. And maybe the last question. What is the minimum SSD limit in Cyberknife?
That depends on the collision table of the Cyberknife, because there is no minimum. It goes up to 600. Minimum is 600, but you can use 600 to 150. Anything in between is selected by the system at the time of placing the align setter, which we cannot set. The nominal SSD is 80 and minimum is 60 and maximum is up to 120 to 130 hours.
Thank you, sir. I thank you once again for supporting this campaign by volunteering this lecture, by sharing your expert knowledge, and also thank all the participants for your active participation. And I welcome you all for the future webinars. See you again. Thank you.
Thank you.